Welcome to a podcast brought to you by the American Academy of Orthopedic Manual Physical Therapists. Our academy is a national organization committed to excellence in orthopedic manual physical therapy practice, education, and research, and we're here to explore a wide range of topics with you through interviews with content experts.
Hello, folks. Before we get started, I'd like to make two quick points. The first is that you're going to hear me introduce Dr. Brown as being an employee of Damon College, which was true at the time of the recording. However, he currently works at the University at Buffalo, which is what you'll see in the show notes. The second point is that this was one of our first interviews, and we were still working on getting our technology details in order. So there's a little bit of a timing issue when we transition from person A to person B. It's not because we were trying to cut each other off. It's just because we missed one of the finer points of recording. That said, it shouldn't take away from the quality of the interview, which should be good and interesting. Hello, my name is Stephen Shaffer, and I'm here with my co-host, Kevin MacPherson. How you doing, Kevin?
Pretty good. How you doing, Steve?
Not too bad at all. I don't know about you, but I am excited today. We have Dr. Michael Brown with us. Hello, Dr. Brown.
Hello. Thanks for having me.
It is a pleasure to have you here. We have Dr. Brown here because of a case that he authored for the AOMT hands-on publication. Before we get into that, let's talk a bit about Dr. Brown. He is a doctor of physical therapy. He also happens to be a board-certified orthopedic specialist. He is certified in orthopedic manual therapy, and he's a fellow of the American Academy of Orthopedic Manual Physical Therapists. Dr. Brown is also about a year away from completing his PhD at SUNY Buffalo. For those of you who do not know, that is the State University of New York system. And Dr. Brown is currently an assistant professor at Damon College, a position he's been in since 2016. I've looked over his CV, and I can tell you that he has a wide variety of publications, presentations, and other accomplishments. But two things I'd like to highlight are that he teaches clinical problem solving in musculoskeletal rehabilitation and also happens to work in a pro bono clinic at Damon College. I want to highlight those two things in particular because clinical problem solving is going to very much relate to the conversation we're having today. And the second one's a bit biased because I too work in a pro bono clinic that's associated with a university program.
That's three of us.
Ooh, excellent, gentlemen. Maybe we'll get on that conversation a bit later. So, Dr. Brown, was that a fair and, let's say, accurate introduction?
Yes, very. And thank you very much for that wonderful introduction. I appreciate that.
I do have to interrupt for 1 second. What's it like being certified in both Maitland and McKinsey?
Surprisingly, it's not too bad. The reason I went down that road was because I see a lot of similarities, even though they are both, kind of at opposite ends of the spectrum. If you want to, look at it, from a 30,000 foot view. They both deal with patient response, and it's how you choose to go about intervening at that moment, whether it's more patient generated or if it's hands-on first. So I think they complement one another because where one doesn't really train you too well in hands-on techniques, the other really prepares you extremely well from how to use your hands to identify a number of issues that might be present. So I think they both feed off one another really well.
I like that answer in part because that's partly my experience as well. I was trained first in the Colton-Born-Evian method, and then later I got Maitland training in, perhaps not as different as the whole McKenzie versus Maitland approaches, but it's like they're still quite different in terms of how they approach and how they think and, the different tool sets they gave me. And I don't know about you, but when I went through that process, let's say the second time, so the second train of thought, my first probably 8 to 10 months were just awful because I was trying to reconcile the differences and fit them into each other and then figure out how I was going to perform in a clinic as a clinician.
Yeah. No, I agree. I did them in succession. My initial training was with, in Maitland, and it's sort of evolved, and I still kind of fight with myself periodically, depending on the pattern that is sitting in front of me, because it's a big thing is, recognizing patterns, and, that's how we become, efficient with that. But, I still kind of find myself gravitating in one direction, gravitating in another every once in a while. And it can be a bit of a challenge, but I still think it's beneficial having both, both sets of experience or skill sets, if you will.
This might be the type of question you don't want to fully answer, and if that's the case, that's fine. But if you had to estimate what percent of the time you use each mindset, what would it be?
Oh, I'm going to have to defer on that because
I thought that might be your
yeah,
answer.
that's I think that's a little hard to answer.
Maybe hard, maybe undesired.
Probably
Either way,
depends
I
on the
won't press.
week.
Yeah, well, we shouldn't press that point.
Mhm.
So, Dr. Brown, can you just give us and our audience a brief introduction to the case, and then we'll go into some more specific questions about what unfolded as you were working with this individual?
Yes, no. So the patient that we're talking about today, he was a student that had approached me after a couple weeks of knee pain that really kind of came out of nowhere. And so we've this is really the first time that I saw him. He was in considerable discomfort and a little worried about the fact that he had this knee pain and he had to back off a number of the activities that he had been doing at that point. He was a commuter, so he would commute probably about an hour and a half every day to just one way to the college, and then he'd drive back. And so he was spending a lot of time sitting in the car, and the drive was becoming quite uncomfortable. Thinking back to the case and looking at what he was presenting with, it was really just knee pain at that moment. And he came to me, he was limping, and he could point to the fact that it was mostly on the inside of his knee, and that a lot of the activities like rising from a chair, walking, going up and down stairs, squatting, a lot of these things were becoming difficult. As many students are at this point, as they're going through a program, and learning about this stuff, they're like, oh, you think it could be a meniscus tear, and he's very concerned that kind of their head goes a little wild, and he was thinking all the worst case scenarios. So I offered to take a look at him and figure out what was going on. So the first thing that really struck me that was a little weird was that his most of his stuff was involved with kind of sedentary or sitting activities. Aside from the transitions from getting up and out of a chair and stuff like that, he complained of a lot of discomfort. When he was stationary, which is a little odd. The fact that it was 2 weeks, and you think something this acute must have had something, bring it on. That was a bit surprising because he couldn't recall anything that he had done to really cause this pain to be present. So it was unique in that instance. So I mean, no injury, really kind of acute, intense discomfort in the medial knee, and really nothing else that he was alluding to other than a history of low back pain that was months previous, and he had never had any no complaints at the current time that his back was bothering him. So
That was an excellent introduction. Thank you very much. I have a quick question here, and that is obviously one of the things that's going to come to the minds of most clinicians when they hear this presentation is it could, of course, be patellofemoral pain syndrome, which is a sometimes difficult entity unto itself. But being an individual such as yourself that teaches clinical problem solving and musculoskeletal rehab, there have to be a whole laundry list of different things that pop into your head in terms of what this type of lower extremity pain could be. Can you speak for a moment about that thought process you have and, maybe for example, like this is the thing that's first on my list, but I have to consider all these other possible things that could be the origin of the pain?
yeah, and there are a number of things that kind of run through your head at that moment when someone's describing their symptoms, and focusing on that little bit of information, or maybe you're trying to find a pattern that's emerging through the history and what the patient's telling you. I think that partly first drives my thought process, because I'm always trying to look for similarities from what I'm saying. And I agree, his presentation right at the beginning, very much sounded like patellofemoral syndrome, based on the fact that sitting could be bothersome, that he has pain with squatting and going upstairs. Those all seem to be related to that kind of pathology. The one thing that was a little different, for me at least, as I started to evaluate them, I typically try to do functional activities first to get a sense of how they're moving and what's provoking their symptoms, especially in anyone who's presenting with lower extremity complaints. My next initial thought process is, since it's the knee in this instance, my initial gut was to take a look at the knee because it seemed to be fairly focal. And my thought being that looking at the knee and moving it, seeing if I can continue to produce or provoke any of the symptoms is going to lead me to further testing of that area. So in this particular case, when I evaluated them, and we went through the functional movements, clearly they were painful. But when I started to look specifically at the knee and look at range of motion of the knee and applying overpressure, it became very clear that that as I moved his knee, it wasn't producing his symptoms, and he had pretty decent range of motion. That you would expect that potentially there might be some irritation, especially if you're in range and overpressing. Given that he was so acute and so sensitive, I would have expected it to be a little bit more painful, and in this case, it wasn't.
Big thing that I was going to ask Mike, if you didn't get to it, what was the flag per se, not necessarily red flag, but the flag that went up that said, all right, I need to go back out of my current patterns and start looking at this from more that hypothetico-deductive reasoning process, if not a little bit inductive. What was the trigger?
A little bit in the history, first off, made me a little suspicious. The fact that, again, there was no preceding change in activity. They have usually some sort of preceding activity that maybe a ramp up in their activity level, change in activity level, training methods, or what have you. Some preceding event that usually sparks it. Another thing that really was a little different is that his location of symptoms, they weren't really over the patellofemoral joint, so they weren't behind, they weren't retropatellar. It wasn't near the patellar tendon. It was really anterior and medial knee below the joint line, so at and below the joint line, which is not a typical location, at least in my experience.
To clarify, was it more kind of in that Pez-Anserine region, or?
Exactly, kind of that Pez-Anserine area and right over that medial portion of the tibia, just below the plateau, along, kind of traveling a little bit more distal. And sensitive to the touch, so you palpated it, and it was exquisitely tender.
And that when I think about the exquisitely tender patient, the next thing I'll jump to is at least a peripheral sensitization component, and we're starting to see that a lot of those changes neurologically can happen a lot quicker than most of us really thought. But I'll agree. Like when we see where you went with the case from a lower thoracic or TL junction region, I was just like, man, it's definitely not the main syndrome that we're used to.
The moment it sounded more like what we were dealing with, like a nervous system issue, some of the complaints in the history, if you take a step back and you think about it, again, some of the burning, the aching, the sudden onset of symptoms, that's one potential mechanism that you need to consider. And the fact that, I'll say for my intents and purposes, kind of the negative signs on, range of motion testing with overpressure of the knee and the palpation. It was my initial thought was to let's take a step back and look at the fact that he does have a history of lower back pain. So that was, for me, it wasn't too big of a leap to head back and kind of say, all right, we should take a look at this. That was the initial step that led me kind of up the lumbar spine into the thoracic spine with some of my passive accessory motion testing, which is when I was really kind of surprised that when I pushed on his TL junction and in and around that area, he was feeling knee pain in the spot that he was feeling knee pain at rest. So it was to have that reproduce a comparable sign. That was a very interesting finding for me. Is the first time that I've seen it. Other people have told me about it, but me personally, I've never seen it. So that was interesting.
You just rolled right into the question I wanted to ask you next, and that is, have you seen this before? Your answer clearly is no. Kevin, have you had patients with a similar presentation, or is this also a new thing for you?
I would say similar, but more classic case, because I've seen them come in and it's more pressing on that L3, that lower lumbar region that I can refer. but I have definitely not been at the TL junction and got a symptom that was at the knee, more or less, in this case, slightly distal to the knee.
This was definitely new for me in that respect because I agree. I think it, in my head, it makes more sense that someone with a lumbar issue, especially around L3, you would anticipate
Mm-hmm.
there being something, or the potential to reproduce symptoms at a knee. But the fact that for me, it was the fact that it was higher, it was like, well, that's new.
After reading it, I ended up going back to the literature. I just started finding studies from the 1900s with Peter Hidgebritz looking at femoral nerve variation, and I mean it makes me wonder if we're dealing with kind of a variation in this specific person that you were able to apply what you knew of the current anatomy and it got you to where you needed to go, but it definitely was not a normal radar finding.
I can actually think back in time to the first time I ever saw a presentation that was somewhat similar to this, and it was about a decade ago, and I happened to be in my fellowship training. It clearly looks like the type of thing that was a lumbar radiculopathy. And every test I ever did on the lumbar spine was completely negative, and I was at a complete loss. I had no idea what to do. I was even extra bad because the guy had some red flags with a history of lumbar spine cancer, etc. But all of his medical screening was negative. So I thought to myself, if I don't explore more, I'm pretty sure this gentleman's going to have no other option. So I just kept going up the chain, and I ended up finding out that he had a case of T4 syndrome. And sure enough, I was pushing, in this case, it was right-sided T4, and I reproduced all of his leg symptoms. And I've actually had, ever since then, I've looked for this. I knew that if it happened with this one individual, it couldn't be the only one that exists, which is exactly why when I saw Dr. Brown's case, I got really excited. And I would say over the years, I've probably in the last decade seen this 5, 6, maybe 7 times. And I don't know, I don't fully understand it, but I find it superbly fascinating.
To jump into it, I just don't want to go too far left field, but whether it was because of or right around the time I was looking at some of the newer stuff coming out of pain science and not even newer, just how we're getting more exposure to it. I just happened one day to be walking down the street and I ended up getting this sharp pain in the first NTP joint. And at the same time, I'm getting contralateral costal pain, like literally like step pain as I go into extension and some on the opposite side. And then I started to read about some of the smudging and some of the other things. So it's gotten to the point where I don't doubt symptoms whatsoever, but I definitely will start scratching my head quite a bit. But it has led to me teaching students in differential diagnosis, which is one of the courses I teach at UF, that they're not done with a patient, regardless of where that person's complaints are, unless they do some quadrant testing of the spine or PA testing to the spine just to clear it out.
Steve, to pick up on your point though too, and I think there's a need to recognize that maybe there are sometimes bigger things at play, with our testing. So peripheral sensitization was brought up a little while back, and I think that there's certainly more of a focus now on pain mechanisms more than ever, and how they are maybe influencing what we do with our patients, or how our techniques are being perceived by patients. So I think here's an interesting case where, again, with this the nervous system, and how it's far reaching. If you think there's not really any sort of break anywhere in the nervous system, it's just this continuous structure and it has its hand in everything. We sometimes maybe get a little bit tunnel vision, and tend to focus only on the one spot that they're having problems. And I think sometimes I'm humbled by the fact that in cases like this, with when you see significant changes, or you're dealing with patients who are a bit more challenging, sometimes appreciating the fact that there's a lot of things that are going on, and it's sometimes more complex than we try to make it. It goes to show that sometimes we need to be on the lookout for stuff a little bit more frequently.
Yeah, I mean, broad thinking is definitely the approach here. If you think that every knee patient that you see in the next year is going to have some sort of major thoracic contribution, then you're probably thinking in the wrong way. But if you also think to yourself that you're not going to at some point see it, you're probably not thinking broadly enough.
Agreed.
I really liked how I'm going to go with the word modified, what we would say is a more traditional way to special test a patient. And you incorporated a whole
Hmm.
bunch of variables that were all, let's say, from different lines of thought, and you put them into one testing regime.
Okay, and are you referring to the the incorporating some of the neurodynamic techniques into functional
Yes, sir,
movement,
I
or
am.
okay, yeah. So I've been playing around with this idea for a little while, and just because again, as I was mentioning previously, that the nervous system has its hand in just about everything, and we know from research that we know our movements can influence how the nervous system moves, and that we know that if we bias the nervous system, we could probably influence the way joints move. So and I, based on the fact that I was starting to think about, how this person was responding, and how it didn't seem like it was an issue specifically with, with the knee. There was an opportunity to really kind of look at to see how sensitive, his nervous system really was. And so, I've started off kind of just so I was on the right track. I started off, in thinking in those terms of, well, let's take a look at the nervous system, and starting with a slump test, and then also looking at the femoral nerve test or tension test, pro knee bend. So I just so that I know I was in the right ballpark. Looking for changes in his symptoms, and looking at how structural differentiation modified those. So that way I could at least know that maybe I could look further into testing this, and then what better way to again see if the nervous system, or the mechanical sensitivity of the nervous system is really impacting function. What better way to combine them? So I had one test that kind of put me down in that or put me in that direction, and then it was really just kind of the next step. And let's just take it another level and add it to function. And it was really interesting to see the results in this particular instance, because by biasing the nervous system from a distal area, in this case his cervical spine, it really had an impact on his ability to move in his lower extremities, or to tolerate that squatting maneuver. It's similar to if you were to extend your wrist first during an Alves test, and then straighten the arm out and look at range of motion at the elbow, and see how that's limited. Or if you were to wind up the upper extremity in the traditional sense, and the very last thing that you do is extend the wrist. If you do it, kind of in the last order I described, you have very little wrist range of motion. But if you do it first, you can get more wrist range of motion, and it applies in so many cases with when you incorporate it into function.
One of the things I was getting at there, which you described, was the fact that you took this functional movement, a squat, and then by biasing cervical flexion and extension, you could turn it into both a neurodynamic test and a weight-bearing functional test. And then you were able, again, to turn it into your comparable sign. So it's this three-part piece rolled into one. And I asked this as a joking rhetorical question, but can you tell me what the sensitivity and specificity are of this testing approach?
Um, my particular approach, nothing.
Correct.
It's
It's an N of one, and that's why it's such a beautiful thing, because if you are limited to, strictly described special tests as they relate to, say, a textbook or what have you, there are so many things in the clinic that you're going to miss. And I just like how you went off the beaten path here. You found the thing that captured your patient's symptom, and you made it into an expert orthopedic manual physical therapy evaluation, treatment, and then follow up. And quite frankly, it's a wonderful thing.
Oh, well, thank you. You make me sound a lot smarter
Well,
than I
I
think I am.
apologize for that. I don't know if either one of you have read this paper yet. It's mostly a commentary, but in the last year, doctors Hegedus, Wright, and Cook had a commentary piece, and the title of it was Orthopedic Special Tests and Diagnostic Accuracy Studies, House Wine Served in a Very Cheap Container. And I mean, they're basically driving at the point that you have to think broadly. You have to pull in variables from all sorts of different directions. It's not this mechanical, prescribed, highly limited approach that myself, but probably a lot of us learned when we were in PT school some number of years ago.
Yeah. No, I've read that article. It was a fantastic article actually, because it highlights exactly what you're saying, that we sometimes read the research and we implement that, but we don't necessarily always think about maybe how that research was conducted, what the gold standard was, that they compared it to, and how does that really really relate. That's a challenge, especially having the opportunity to work with students who are going through entry level programs, that sometimes they want to have yes and no answers, and sometimes it's okay, if I do this test I'm going to get this, and sometimes it unfortunately it's not that simple, and we need to really appraise the literature to get a real good sense of how applicable is what I'm doing. And then we also have to question sometimes, in the broader context, or at least this is how I'm starting to think, if we dive down this rabbit hole that's pain mechanisms, what do these tests really mean? And if we do them in someone who has central mechanisms, how reliable is that test, especially when there's such sensitivity to, in some cases, how things are moved.
Yeah, I agree completely. And part of the point that's just ringing in my head right now is the fact that, yes, of course, being scientists and consumers of science, we are interested in what the literature says, but sometimes the case study, which is perhaps the lowest level of scientific evidence, can be extremely informative. And that's part of why we're here today. We're highlighting the way people think, the way they approach patients, and some of these clinical pearls that come out of the whole case study process. It's valuable in my opinion.
I agree. I think it's very valuable.
So obviously, it's been a little bit of time since this case was complete, and based on your description, I'm assuming you still have somewhat regular contact with the patient, unless, of course, they graduated or, dare I say, failed out. Can you give us a quick update on how your patient is doing?
So no, I have had contact with him, and he's doing well. Actually, he's training for a marathon right now, or excuse me, not a marathon, a triathlon, which is good because that was one of our ending points. Was how does he become more active and take better care of himself? So that was something that he really wanted to do and has been working toward now for the last year or so. He's doing well. He did have a reoccurrence. He was good for probably almost 6 months. So he was out on his internships, and actually, when he came back for the next academic year, he actually was starting to develop a little bit of symptoms that, upon talking with him, he was actually able to self-manage, and it was very short-lived, which was I was very pleased to hear that. And like I said, as he's been training, he actually had a little spill on his bike, and hurt his wrist and a few other things, kind of tweaked his back a little bit, but was never the symptom that came back. So it was never really knee pain at this point. So I've seen him a couple times just to have conversations, but we've never had to institute treatment again.
To me, that sounds like a successful outcome. And quite frankly, as clinicians, we should all be acutely aware of the fact that the thoracic spine and rib cage are, of course, inherently stable, which I always tell my patients and students is a good thing, bad thing. The good thing is you trip, you fall, you don't squish your heart and lungs and die. The bad thing is it has a tendency to tighten up over time because it's inherently stable. And I of course, don't think it's any sort of failure for a patient with a thoracic impairment to have to use a home exercise program to maintain flexibility.
Yeah, I've been actually I was very pleased, and so was he. The fact that he had really started to do a lot more training, and I've personally have never done a triathlon. I tell myself I'd like to do one once the PhD's done, but I think I might be joking myself. But he's, to be able to do that level of training and not experience, and just experience a little bit of symptoms, I think is a huge win in this case.
I certainly agree. Kevin, any final thoughts on that?
Yeah, I mean, the final thought that I would bring to the table is really focused on the last part that Mike said, and that is the tremendous benefit that our profession provides to society by not just doing a treatment in the moment, but also giving patients ways to self-treat going forward. And that's a huge impact that we can make, especially with the whole opioid epidemic and therefore response to it. that's so well publicized at this point. And I think that is also something that doesn't pan out quite as much as I'd like to in the research, because oftentimes when a person's discharged from the research study, they're not really told, hey, you can keep up with these exercises and keep yourself moving or whatnot. And I think some of the long-term outcomes from those studies might not be reflective of some of these changes, especially in the more prescriptive studies as opposed to the pragmatic studies. So I think that's an excellent point. I'm glad we were able to get to that.
I could not agree more. So I don't know about the pro bono clinics that each of you are working in, but one of the things I've noticed here, and this of course is to a certain extent true in any clinic in our country, unfortunately, as Kevin was just pointing out, there are way too many prescription medications. You specifically mentioned opioids, but I see so many patients who have, they go and they see a physician or whoever, and they're just put on so many medications to manage these symptoms that, it often turns out are relatively simple musculoskeletal impairments. And if they had been seeing a physical therapist, and perhaps I would even go further and say a physical therapist with higher level training, like, for example, academy training, a lot of these problems I think could just be managed up front and then not turn into some, chronic, difficult to manage impairment.
I would concur with that, and I think that it is a certain challenge that we have, and I think it's a positive challenge that we can get behind it, and we can rise up and we can do a lot of good for individuals who are having to resort to that line of treatment. And it's unfortunate. I'm thinking right now. The reason I'm kind of pausing, I'm thinking about a patient recently that I just had a chance to work with, and it was an acute flare-up of a previous condition and it was quite painful, unfortunately. And we were trying to get her in to see another specialist because it was something that was a little bit beyond what therapy could do for her at the moment. And unfortunately, the pain was so great. She ended up going to the emergency room where she was given some fairly strong opioids and multiple other medications, opioid-like medications to control her pain, with unfortunately little success. It's a real challenge, I think, at this point. And I mean, thankfully, we're hearing some stuff that that at least the prescription medications, opioids, are declining within recent months because of all the publicity. But it's still an issue, and I think therapists are really in a great spot to help, with more conservative means and safer avenues.
I agree. Well, with that, let's make that our last major comment for the day, since we're running a little bit long here. So I'd like to thank Dr. Brown for coming on the podcast today and talking with us about this highly interesting case that he had. So thank you, Dr. Brown.
Mm-hmm. Good to talk to both you
guys.
Thank
you for the opportunity. It was a pleasure.
I look forward to seeing more work out of you, Dr. Brown, going forward, especially after you get those final set of letters and start contributing more to our research body.
This has been a production of the American Academy of Orthopedic Manual Physical Therapists. You can learn more about the Academy by visiting our website at aaompt.org. You can also find us on Facebook, Twitter, and Instagram by searching for our acronym AAOMPT.